Good evening, everyone. So this week we'll be continuing our discussion on cutaneous, connective tissue disorders. And in previous 2-3 weeks, we were discussing SLE. We have discussed the pathomechanism of SLE, and last week we discussed discoid lupus erythematosus. Now, as we said in that lecture, that DLE is one of the most common form of chronic cutaneous lupus erythematosus. So, if you have chronic LE, you have acute LE and subacute LE also. So in this week's lecture, we'll discuss acute LE and subacute LE together and see what are the clinical features, the pathomechanism, and what are the subtle differences between acute LE and subacute LE, and why is it important that we need to differentiate these two entities. Okay, so without much further ado, let's start a discussion on acute and subacute LE. Let's move forward. Now, the classification between acute LE, subacute LE, and chronic cutaneous LE was given by Dr. Gilliam along at all. There were many people involved. And what Dr. Gilliam did was to divide LE on the basis of histology. So on the basis of histology, two classes of lesions were divided. One was LE specific, which showed interface dermatitis in their biopsy. Interface dermatitis. While the second criteria of lesions were non-LE specific skin lesions, which showed different histopathological features and also were seen in other disorders apart from LE. So they were not specific to LE, while you have a certain cohort of lesions which were specific to lupus erythematosus. Okay. Dividing LE specific lesions. So dividing LE specific lesions, Dr. Gilliam divided into three parts: acute LE, subacute LE, and chronic cutaneous LE. Okay. There's a certain fourth part also. Some authors consider intermittent cutaneous LE, and the example of intermittent cutaneous LE is LE tumidus. Some authors consider that, but Gilliam's classification had only three parts: acute LE, subacute LE, and chronic cutaneous LE. Okay. Acute LE was characterized by transient malar rash. Subacute cutaneous LE was in a photosensitive distribution and healed without scarring or atrophy. While chronic LE, most common type is the discoid lupus erythematosus, which is a scaly erythematous plaque which heals with atrophy and scarring. So atrophy and scarring is seen in a chronic cutaneous form, while in the subacute cutaneous form, they heal with minimal to no scarring or atrophy. Okay, so that's how it was divided into three aspects. Let's move forward. Now, if we talk about ACLE, the ratio is about 1:8 male to female. That means females are 8 times more involved with ACLE. Clear? Now this ratio somewhat mimics what we see in SLE. The SLE, the ratio was somewhat similar to as high as 1:9. So the ratio is somewhat same, and that actually further strengthens the belief that ACLE lies towards the systemic aspect of manifestation of SLE. We have localized acute cutaneous LE, which is exemplified by the malar or the butterfly rash, and it starts in about 20 to 60% of patients. That means about 20 to 60% of patients will develop the first symptom or the presenting symptom as malar or the butterfly rash. If it becomes generalized, it presents as a maculopapular eruption or the SLE rash of generalized ACLE, and that is seen in about 35 to 60% of SLE patients. So we have two types of ACLE, localized and generalized. Localized is involving the face in the butterfly region, while generalized is more of a maculopapular eruption involving the whole body. When we discuss SCLE in epidemiology, about 7 to 27% of SLE patients can present with SCLE first. So in SCLE, we have more of a photosensitive distributed scaly plaques. So scaly plaques on a photo-distributed area, while in ACLE, we have the central face which is involved. Clear? Let's move forward. So let's discuss separately ACLE and SCLE, and then we'll combine and discuss them together. ACLE in its localized form presents as malar erythema. In its localized form, this malar erythema is known as butterfly rash. Why butterfly? We know that it looks like the wings of a butterfly. Very bad drawing. It looks like the wings of a butterfly. Again, bad drawing. Bear with me. I'll leave it as it is. So, in ACLE, what actually happens is that this involvement of the malar region, the bridge of the nose, and the other malar region, So it looks like a butterfly, and that is why it is known as a butterfly rash. Clear? Now, this butterfly rash is bilateral, involves both sides of the face. Transient, that means it resolves without scarring. Follows sun exposure, and it gets improved without leaving any sequelae. Maybe mild pigmentary issues like any post-inflammatory changes of pigmentation, but mostly it resolves without scarring. It involves the center part of the face, the central face, the muzzle area, the butterfly area. Autoantibodies like anti-DS-DNA is found to be higher as compared to SCLE while in ACLE. Okay. Duration of the rash is roughly about few hours to several weeks. So it depends on the inflammatory process. If the inflammatory process is prolonged, the rash is prolonged. It's distributed in the central part of the area and it follows sun exposure or acute UV radiation damage. Okay, let's move forward. Now, when the area of the involvement is the entire body or other aspects apart from the face, neck, and the V area of the chest, we call it as generalized ACLE. In generalized ACLE, the eruption is more in the form of a morbilliform or a measles-like rash or an exanthematous eruption, somewhat mimicking viral exanthema. Okay, so that means that the inflammatory process is involving other parts of the body also. The extra parts are the extensor arms and the hands most commonly, and these are also the parts which are UV exposed. These are exposed to the sun. But if the hands are involved, the knuckles are spared, and that is a good differentiating factor from dermatomyositis. In dermatomyositis, we have lesions of dermatomyositis over the knuckles. The knuckles are spared in generalized ACLE rash. The rash is also known as maculopapular rash of SLE or photosensitive lupus dermatitis or SLE rash. These are other names for generalized ACLE rash. Okay, let's move forward. Hi, hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. Um, you get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video. Now let's understand the pathophysiology or the pathomechanism of acute cutaneous LE, and it is a similar pathomechanism to SCLE also, subacute cutaneous LE. Now, what we'll do right now is we'll just summarize it very quickly and very in a short manner. But if you want to know about the detailed pathomechanism of SLE, we have a separate video on that. We did cover the pathomechanism of LE about 2 weeks back, so you can go back and look at that video. It's a very extensive video to tell you about the pathomechanism underlying lupus erythematosus. Now, in short, you have UVA radiation that damages keratinocytes. These damaged keratinocytes start the inflammatory response by releasing all sorts of cytokines, by also damaging the matrix proteins and releasing matrix metalloproteinases or activating matrix metalloproteinases, and also releasing a bit of antimicrobial peptides as a reaction to inflammatory damage because of UV radiation, and undergoing apoptosis. And this apoptosis releases DNA and all the nuclear materials or the proteins which were inside the cell. They release these contents in the circulation, and immune cells recognize these molecules and start preparing autoantibodies. Now, one of the important autoantibodies are the anti-Rho and SSA antibodies against autoantigens. If we are discussing about ACLE, then anti-DS-DNA becomes more important. But in SLE, this is for ACLE, but in SCLE, anti-Rho becomes very important. So anti-Rho SSA antibodies are more important. Clear? Additionally, the UVA radiation also increases the expression of antibodies over the keratinocytes. So normally these molecules, these Rho molecules, these SSA molecules are inside the cell. But if the cell is destroyed, they will be released outside and immune cells will recognize and form autoantibodies. Clear? Under the UV radiation, antibodies or the antigens, the Rho and SSA antigens, they are exposed to the cell surface. And if these protein molecules are exposed to the cell surface, they will be recognized by the Langerhans cells and the immune cells, and they will start to activate the innate and adaptive immune system to start forming autoantibodies. Okay, so this also additionally leads to anti-Rho and SSA antibodies. Now these antibodies start an inflammatory response or an immune response, and these immune cells will come and cause damage at the dermoepidermal junction. So there will be damage at the DEG and the epidermis and the destruction of epidermis, and more the epidermis and dermal tissue is destroyed, more of these particles are released and more autoantibodies are formed, higher the inflammatory response, and it starts an inflammatory cascade which increases or results in a very robust inflammatory response, causing the clinical symptoms of rash or papilloscomus eruption in SCLE or ACLE. Now this is this is how the immune response eventually leads to SCLE or ACLE, depending on what is the type or what is the type of cytokines released, what are the type of cells which are activated, what are the different types of molecules which are released in between the inflammatory cells of the innate system or the adaptive system. Clear? This is just a very short way to explain the pathomechanism of ACLE and SCLE. Okay, so we have summarized, we have discussed ACLE in the previous few slides. Let's come to SCLE. Now, SCLE, as the name suggests, is the subacute cutaneous LE. So, acute LE in which the rash lasts for about few hours to few days. In SCLE, the lesions are more prolonged. They are photodistributed. They are over the areas which are photoexposed, but the lesions are prolonged as compared to acute LE. Okay. SCLE is characterized by erythematous macules or papules, which are over the photosensitive area or the photodistributed area, and as the time passes they become more scaly and thickened. Okay, so more hyperkeratotic and papillosquamous. They can have other morphologies like the annular or polycyclic plaques. So they can have essentially a scaly plaque over the photodistributed area, or you can have a somewhat of an annular morphology in which you have a central clearing. Clear? The distribution is over the sun exposed area like ACLE, but in ACLE the rash is limited to the middle of the face, while in SCLE it can involve the entire of the area of the neck, the exposed area, the nape of the neck and the back. All the four sun exposed areas can be involved. Now the areas involved are the upper back, shoulders, extensor aspect of arms, the V area of neck, and the lateral aspect of the face. Now this is important. The lateral aspect, that means the sides of the face are involved. The central is not that much involved. Okay. The center part is mostly seen in ACLE. It's a feature of ACLE, while in SCLE it's the other areas which are involved. They do resolve with hypo or depigmentation. That means pigmentary anomalies are there. They can in fact resolve with telangiectasias also, but there is no scarring, and that differentiates from DLE. So DLE they heal with atrophic scarring, while SCLE they heal without any scarring. Photosensitivity is seen in about 27 to 100% of patients. So you have more complaints of photosensitivity in patients of SCLE. Clear? Let's move forward. Good evening everyone. I hope you are enjoying this video, and I've come again to ask you to vote for Delhi for Dermacon 2028. So with the support of IDBL Delhi State Branch, do vote for Delhi and come and meet all the dignitaries here, and let's have a good academic discussion in the backdrop of the cultural heritage that Delhi offers. So enjoy this vibrant city that I duly call my own, and if you follow this instruction to become an e-voter, you can just easily vote on the IDBL website. It hardly takes less than a minute, and it's better to vote as early as possible. Will help you in tackling all those spam calls that you get. So make sure that you choose Delhi as a good venue in 2028, and let's meet there. I shall see you in Delhi. Bye bye. Let's discuss what are the biopsy findings of ACLE. The ACLE biopsy shows only subtle features and is characterized by cell-poor interface dermatitis. So it is interface dermatitis, but the level of infiltration is very, it's less, it's little. It shows mild focal vacuolar degeneration at dermoepidermal junction. Telangiectasias in the form of dilated capillaries and RBC extravasation is seen. In severe ACLE cases, you can have extensive epidermal necrosis, which we usually see in the TEN variant of ACLE. Okay. The upper dermis can show pronounced mucinosis because of being more at the sun-exposed areas. In immunohistology, you will see the lupus band in about 100% of the cases. So in nearly all of the cases, you will see lupus band positive if you take it from a lesion. It presents as granular deposit of IgG more than IgM at the dermoepidermal junction and the perifollicular location. So if we have a biopsy and this is the dermoepidermal junction, you will see the granular deposits like this, okay, granules. But if it is significant, it can even form like a band. Clear? Let's move forward. Okay, now come to SCLE. In SCLE, the epidermis can be atrophic with vacuolar interface dermatitis. Hyperkeratosis is important. It's an hyperkeratotic lesion, remember. The interface change or the interface dermatitis is intense with many cytoid bodies. So cytoid bodies are seen. The inflammatory damage is more as compared to ACLE. Remember, SCLE is more edematous than ACLE. It is more inflammatory as compared to ACLE. Basement membrane thickening can be also seen. In dermis, there is superficial perivascular lymphocytic infiltrate with superficial mucin deposition. So same as that of ACLE, but more inflammatory damage, more infiltrate, more significant inflammation, more significant lymphocytic infiltrate. But it shows less prominent follicular plugging and pigmentary incontinence, which is a feature of DLE. In DLE, you have follicular plugging, pigmentary changes. So these changes are very less in SCLE. In drug-induced SCLE, you can have other features like leukocytoclastic vasculitis, while in annular SCLE, you can have robust basal degeneration with epidermal necrosis, with or without epidermal necrosis. And if epidermal necrosis is seen, you can have the, erythema multiforme like lesions, which is seen in Rowell syndrome. So in Rowell syndrome, you have EM-like lesions in a lupus patient. Clear? Let's move forward. In immunohistology, you will see lupus band in about 65 to 80% of lesional biopsies, while this was as high as 100% in ACLE. The deposition is of IgM, IgG, and C3 at the dermoepidermal junction and the perifollicular location. In about 20% of non-lesional biopsies, you can have lupus band positive. But now we don't do lupus band. However, if you take a biopsy from LE patient, do send another sample for DIF also. A dust-like staining pattern is also, described, in which you have fine particles of immunoglobulin deposits throughout the epidermis and superficial dermis. It's more like dusting. You just spray some kind of dust in between the cells, and that is what is known as dust-like staining pattern. Okay. Now, the differential diagnosis of acute cutaneous lupus erythematosus include rosacea, seborrheic dermatitis, sunburn or phototoxicity, drug-induced photosensitivity, dermatomyositis, erysipelas, pemphigus erythematosus and pemphigus foliaceus, and atopic dermatitis or contact dermatitis or photocontact dermatitis. Clear? So these are all the dermatoses which are over the malar region. In subacute cutaneous lupus, since we have scaly plaques, the differentials include psoriasis, dermatophytosis, photolichenoid drug eruption, polymorphous light eruption, granuloma annulare because of thickened indurated margins, figurate erythema like erythema annular centrifugum, dermatitis like atopic dermatitis, contact dermatitis, and or pemphigus foliaceus because these are also scaly plaques over the chest and back in pemphigus foliaceus. So these are very important differentials of SCLE. Let's move forward. So regarding the treatment of these disorders, I will not cover them in detail. This is the table I've taken from Bolognia. You can go back and read. It's on page 686. It's same as what was there in DLE or what is there in SCLE. In subsequent weeks, we will discuss the EULAR guidelines for treatment of SCLE, and we'll cover them in somewhat detail. I'm not covering them right now. Okay, let's move forward. So these are some reading recommendations. Otherwise, you can just go through this video, and your confusion, if any, regarding what is ACLE, what is SCLE, is clear. So if you combine this video with the last week's video of DLE, we have completed the cutaneous manifestations of SLE. Okay. Again, requesting you to take membership. I do plan to discontinue Ruby membership in few months. And if you think these videos are helpful in your residency or afterwards, do consider becoming a Sapphire member. You have access to longer videos, bonus content, and special separate videos which are made for Sapphire members. So with that, I finished this week's video lecture on acute cutaneous LE and subacute cutaneous LE. ACLE, SCLE, and DLE combined together forms your cutaneous manifestation of LE, and that is more or less which covers every aspect of SLE that you may, you will have access to in the form of patients. We will discuss what is the EULAR guidelines for management of SLE in subsequent weeks to understand better how to manage cases of lupus erythematosus. If in any scenario the skin is involved, then the patient is ours. We have to manage that patient on our own. We need to have a deeper understanding of what is this disease known as lupus erythematosus. Clear? Any doubts, just mention them in the comment section with the timestamp, and I do make sure that I'm as soon as I get the time, I'll reply. And in fact, you can email me separately if you want. With that, I won't take much of your time. Adios. Bye bye. I shall meet you next week, and happy and prosperous Diwali. Okay, bye bye.